So I think without further ado, we'll probably just kick things off really with osteoarthritis. And for everybody that's listening and watching, we're just going to go through sort of a series of things, kind of a little bit about the condition, history, exam, investigation, management, and when you refer on, to just give you that full understanding. And I'll try and guide us and bridge us between physio and surgery wherever possible. So starting with osteoarthritis, obviously, it used to get spoken about as though it's like wear and tear. And I used to get told off for saying that because they like to refer to it as wear and repair, as I understand is sort of the present vernacular for it. So I'd like to know a little bit more about the condition, I suppose, even myself, Khaled. What sort of people do you tend to find OA of the knee in that you've seen in practice?
Sure. Thank you, Jack. What kind of people present with OA? I think we tend to, having worked in orthopedic, and of course, an orthopedic consultant, I'm going to ask we'll ask his opinion in a second, but working in orthopedic clinics with a knee consultant, you find that there's often a transition period. You don't get people suddenly turning up or you don't always suddenly get people turning up at age 70 saying, my knee hurts. There's very often you get to know patients from the age of, let's say, maybe 45, 50, coming in with a little bit of a grumble in their knee. Often the consultant will look at someone's osteoarthritis between grades 1 and 4, where 1 is very mild, very often asymptomatic, and grade 4 being serious arthritis or severe arthritis, some would say. And you sometimes find this process where someone might enter the clinic at, let's say, age 45, 50, and they have an MRI of their knee, or they have an arthroscopy of their knee, which allows the consultant to have a look inside, the best examination you can ever do, an arthroscopy, because you can see the tissue as a surgeon. And I'm sure Ray will talk about that as well. And so it might be that from then you'll start noticing their notes will say signs of grade 1 or grade 2 OA, and those OA signs might be on the medial femoral condyle, on the lateral femoral condyle, on the medial tibial plateau, on the lateral tibial plateau. And then as that kind of progresses, you sometimes see these patients coming back saying, yeah, I had the arthroscopy a couple of years ago, but it's still was a bit sore, and it was better for a bit after the scope, and now it's been creeping back in. Okay, well, let's maybe think about another scope. And then they have another scope, and then the notes after the operation now say OA grade 3 medial femoral condyle or lateral femoral condyle, and then they sometimes go on to have further more even more invasive larger scale surgery when they have osteotomies and unilateral compartment and total knee replacements, which we can talk about in a little bit. So sometimes you see that very much progression of people within clinic, but a lot of people will go to an orthopedic clinic from physiotherapy. So they'll go and see Jack as a GP. Jack will say, right, looks like you've got a knee problem, let's refer you to the physio. And then they will be seeing the physio for a long period of time, and it might be that within some trusts or some areas of the country there's very specific criteria in order to refer someone for surgical opinion on an osteoarthritic knee. And until they meet that criteria, whereby they're really struggling with their quality of life, they're really struggling with pain control, etc., that's when they go to see the consultant, and by that time they do have quite advanced progressed.
Sure. So that's really interesting. Thank you, Kai. So talked about a middle-age group progression, and we rarely see those that come in that are much older, just suddenly with really severe arthritis. Okay. So one thing I'm quite interested about knowing more about the condition is often that radiologically refer to sort of unicompartmental and there's tricompartmental. I just want to bring in Ray here and just tell me a bit more about what that actually means when people say tricompartmental arthritis of the knee.
No, that's fine, Jack. Can you see me at all? My picture's not on the screen at the moment.
We've got you, Ray. Got you, Ray.
That's great. So knee surgeons tend to classify the compartments of a knee into 3 different compartments. So it's not just one compartment. They're all connected. So when we talk about compartments in the knee, we talk about the patellofemoral compartment being as one compartment, and then the medial compartment and the lateral compartment. And these are graded differently depending on grade 1 or grade 4, whatever grade these compartments are. So when you talk about tricompartmental osteoarthritis, we're talking about osteoarthritis affecting all 3 compartments, the patellofemoral joint, the lateral compartment, and the medial compartment. Now, when you talk about unicompartmental osteoarthritis, then we're talking about whether it's just affecting the patellofemoral joint, or whether it's just affecting the medial compartment, or just affecting the lateral compartment. And this is really important because the treatment modalities are different for each of those particular conditions. If you've got tricompartmental osteoarthritis, then the only available option is to do a total knee replacement. That involves replacing both the tibiofemoral articulating surfaces as well as the patellofemoral joint as well. Now, for example, if you've got just medial compartment osteoarthritis, then there are options available for replacing just that particular compartment to preserve the knee. So it's bone conserving surgery. So medial compartment osteoarthritis can be treated with a unicompartmental knee replacement. But again, it depends on the age of the patient, the expectations of the patient, and the activity levels of the patient.
Sure.
So that's what we refer to when we're talking about different compartments.
Great, and I suppose this brings in what Tom mentioned, which is quite it's a great question, which is about why medial arthritis or medial compartmental arthritis tends to be more common. Perhaps the reasoning behind that.
Yeah, the reason for that is that the weight-bearing axis goes slightly medial to the tibial spine. So the majority of the weight bearing is on the medial aspect of the knee. Also, if you look at the cross-section of the tibia, it's in slight varus as well. So that all predisposes for osteoarthritis occurring on the medial side. But remember, in rheumatoid arthritis, you do get osteoarthritis affecting the lateral side. But just beware that in rheumatoid arthritis, it's still more common on the medial side. But if you get lateral sided compartment osteoarthritis, it's usually somebody with rheumatoid arthritis. Or we'll come on to later on, if you take out the lateral meniscus, that predisposes to severe osteoarthritis on the lateral side. So that's the reason why medial compartment osteoarthritis is far more common.
And then the final bit really about sort of the condition that I just wanted to touch on is perhaps we can come to Khaled for this one is kind of this idea of wear and repair. And, that we used to say wear and tear, but there's this change in vernacular and kind of why that is really.
Sure. I think, and of course, I'd love to get Ray's opinion as well, but I think a lot of it comes down to a lot of things that we are discussing in the medical world at the moment and the impact of such terminology on patients' understanding. So this concept of wear and tear, I think, often paints this picture for patients that if they're a 45, 50-year-old lady or man and they hear that they have wear and tear in their joint, that they often feel as if there's no coming back from that. It's as if, number one, it's worn and it's tearing. Oh, crikey, now I really shouldn't be moving my knee. Now I definitely need an operation. I definitely need something doing about it. And I think that the idea being is that wear and repair paints, it paints a more optimistic picture, but I think it also, gives some credit to bodily processes of being able to, maintain the condition, trying to have an impact of some kind of self-healing as well, and moving away from this idea that once someone has osteoarthritis, it's a very downhill road and there's no coming back from it. But Ray, I'd love to hear if there's any thoughts from you on that kind of subject.
Yeah,
This is your area.
It's a very interesting point. It's very important to realize that not all osteoarthritic changes in the knee will always progress. Now, that's the very important thing to realize, that patients with osteoarthritis may have those particular findings for several years to come, and it may not progress. So you've got to be very careful whether you treat the osteoarthritic changes in the knee or the symptoms that the patient has. It's the symptoms that are far more important than the actual degenerative changes or the osteoarthritic changes in the knee. Now, the symptoms may progress, but the osteoarthritis may not. So you've got to be very, very careful what you treat, not the osteoarthritis, the symptoms. And that's the most important thing.
I suppose that kind of brings us quite nicely then, before we come back to some of the other questions, onto the symptoms and the history. If I come to you, Ray, and just ask, what are sort of like, you know, without going through the whole history taking process, what are the key bits that you're looking for when that person comes in, before you've got any other information that sort of hints to you that this is an arthritic problem at the knee?
Well, it's usually a throbbing pain which interferes with their quality of life. And, you know, this is what you need to suspect that in elderly patients when they come to you. They've got severe pain, it's unrelenting, it's interfering with their quality of life, they can't sleep, they can't walk, and that would suggest to me that they've got an arthritic knee. Clearly, when you examine them, then that will confirm that, and x-rays will confirm it even further. But it's the unrelenting pain and the interfering with the quality of life that's the most important.
And are there any sort of specific examination features? You know, so you've got this throbbing pain in the knee that's been progressing for a number of months. It hurts when they're walking around, on it a bit better maybe when they're resting. What examination features are you trying to pick out, or sort of to look and say, that's probably an arthritic knee? I mean, in physiotherapy, for example, they talk sometimes about a capsular pattern at joints with arthritis. I'm just interested from an orthopedic stand, do you use anything like that? Or
we don't normally use things like that. What we normally do is they usually have a varus or a valgus deformity when they stand, and you can only assess the deformity when they're standing. That's very important. They usually have a fixed flexion deformity at the knee as well, and that is another key sign that they're developing osteoarthritis in the knee. And their flexion is reduced. Usually most patients with osteoarthritis can barely flex greater than 90 degrees. If it affects the patellofemoral joint, they normally say they can't kneel down, and they can't go up and down stairs, and they can't stand from a sitting position. That's classical of patellofemoral osteoarthritis. So those are the key things that you look for. Fixed flexion deformity, and effusion is also present. And also they have a varus or a valgus deformity when they stand.
Brilliant. And I guess this sort of briefly comes into the investigation aspect of things. Would you always generally get an x-ray on people with arthritis?
Always.
Yeah,
always. You get a standing x-ray, because the standing x-ray is really important, because that's loading the weight-bearing surfaces, and that will tell us far more in detail when you weight bear the surfaces whether there's bone-to-bone contact or not. So you need to get an AP standing, a lateral, and a skyline view, which looks at the patellofemoral joint.
That's really interesting, because, you know, I mean, certainly in my practice in primary care, that you get pushed quite hard not to do.
Oh no, we normally prefer that they're referred with an x-ray.
Yeah.
that's really good. But if they don't, then obviously we'll obtain the x-rays there and then.
I suppose that one of the narratives that gets pushed both within general practice and when I was doing physiotherapy was this concept of, if you're not going to be operating right now, or not considering an operation, why would you image at this point? Because it's not going to influence what you're about to do. That's sort of, I suppose, one of the things that's pushed to stop you from x-raying absolutely everybody that walks through the door. But I suppose from your perspective, Ray, would you generally err on the side of, if you think it's arthritis, as a general rule, even if you weren't going to immediately go for surgery, you'd probably get an x-ray?
I would always get an x-ray. Because in future, if they present again, you can compare the x-rays.
So I guess that brings on, with the investigations, one really interesting point, which is the lack of correlation between the amount of wear that's in a joint and the amount of pain that it's causing an individual. And sort of, that from perhaps either perspective, really, why is that? Why is it you can have sort of mild arthritis and horrific pain, or severe and not that much?
That's a very good question. The one thing you must make sure that you observe is that if they're getting so much pain with very little osteoarthritic changes, look at the hip. Because you can get severe referred pain from the hip, and you can be caught out with that. So if they are presenting with knee pain, which very little wear and tear on the x-rays, get an x-ray of the hip and examine the hip. But you're quite right, Jack. There are some situations where the x-rays don't show very much evidence of osteoarthritis, but they're in severe pain, unrelenting pain. And you look at the x-rays and you think, I can't explain this. The next step would be to do an MRI scan of the knee to see why they're having so much pain. Is there another cause of the pain? So look at the hip first, examine the hip, do an x-ray of the hip. If that's normal, then do an MRI scan of the knee. Sometimes you don't know why they're getting so much pain. You really don't. And, you know, it's a diagnostic challenge sometimes. But you can proceed and get an MRI scan, and that might give us more information why they've got so much pain.
So I guess probably an appropriate time to just quickly kind of summarize briefly. Probably I have to forgive me, I might not be able to get every single point, but we've talked about this middle-aged person, progressive pain over time is that classic person that comes in when you take the history, that throbbing pain in the knee that's sort of stopping them from doing their regular activities. And you said, Ray, about kneeling and walking up and down stairs, things like that, as just something to think about as part of which part of the knee might be influenced. And then when we came to sort of examination, we were talking about maybe when they're standing, having a valgus deformity at the knee. So kind of, I suppose, the knees facing one another, like inwards. Are we talking about here? Or are we talking about the like knock-kneed almost? Is that what we were referring to with valgus?
So when you look at a normal alignment of the legs, you're in a slight bit of valgus anyway.
Okay,
that would be exaggerated in a valgus knee. Yeah. But as we mentioned earlier, Jack, the most common deformity is a varus knee because you're loading on the medial side. Okay. So it would be the opposite to a valgus knee. You get a varus knee. So So that's varus knee deformity. And then you said about the fixed flexion deformity. Khalid, you were going to say, sorry. For a flexion deformity, you usually get a fixed flexion deformity of 10, 15, 20 degrees.
So they can't straighten their knee fully.
They can't straighten their knee, but it's a fixed deformity.
Yeah. And Khalid, what were you going to say about the...
No, absolutely coincide with Ray. Varus is more common and more indicative of medial OA. And actually, when I worked with a knee surgeon, he would often say that actually he quite likes it when the patient has a 5-degree valgus. Yeah. That's quite a good position. So when you immediately see valgus, don't panic. Sometimes a 5-degree of valgus is actually quite a healthy position to stop that varus progression.
Yeah.
Well, okay, so we've kind of gone through the basic bits there. We then talked about, getting x-rays, and then if you've got mild arthritis, really bad pain, just think hip or scan with an MRI perhaps. So, okay, so we've got a classical patient, they're in pain, you're pretty sure it's arthritis, your x-ray confirms it, right? So they're going to physiotherapy. I've given them some painkillers in GP, or they bought some over the counter, something like paracetamol, and of course the non-steroidal anti-inflammatories like ibuprofen. So they come to you, Khalid, with their arthritis of the knee. What are you going to do to try and help it and stop them from needing surgery quicker?
Yeah, great shout, Jack. So I'll try and see if I can answer some of the questions in the chat from this, because I think lots of people often have questions about this with the questions in the chat. So education is naturally always going to be a huge part of things. We're going to be talking to them about this concept, as Ray said earlier, that patients with arthritis, it can be asymptomatic, but also it doesn't mean it has to progress if we can keep things under control. We talk about pain relief as a piece of education, because often people say, oh no, I don't think I want to take it, or this, that, and the other. And it's important to remember the NICE guidelines. So some of the NICE guidelines for physiotherapy talk about local and aerobic conditioning or strengthening, local being the quadriceps muscles, the hamstring muscles, the calf muscles, perhaps. And the idea there is that one of the key things about that kind of local strengthening is that you're trying to help the joints tolerate load better. Yes, the strengthening the muscles will have an effect on supporting the joint, but I do think there's a lot to be said for helping the knee tolerate load. And therefore, that in itself is another really important piece of advice about telling your patient about load management and activity and lifestyle moderation, if appropriate. So for example, it might be that if they're in that kind of flare-up stage, some simple tips like, what if we were to reduce our activity for a short period of time? I don't want you to stop playing golf forever, but might it be the possibility that instead of playing 18 holes every 3 days, what might happen if we did 9 holes twice a week? And you see how that goes for a bit. Just activity modification, patient appropriate. The NICE guidelines talk about weight loss, which is a huge and very exciting and very interesting topic that we speak about a lot. And I know Ray will have his experiences of that being on the surgical side of things. We talk about footwear and having comfortable, reliable shoes. We talk about the potential use of walking aids as an adjunct to help people take weight off their injured knee, which can sometimes be a challenging conversation. I'm sure that one day when I get to that age where a physiotherapist says to me, "Oh, do you think you might benefit from a walking stick?" I'm sure my first instinct will be, "Oh no, that means I am definitely going downhill." But sometimes that's a topic, a question you have, and I think when I've had that conversation with people in the past, I've been very mindful that can be a psychological challenge. And so if they say no, then I will say no problem, totally understand. Maybe I might just ask you to consider it, and if you think you want to try it next time, then do, because I totally understand it can be a tough one. Jamie's question was, what are the main early intervention strategies? Hopefully I've asked that. Prevention measures, hopefully we've asked that. And yeah, there's some other questions about some other orthopedic stuff, but hopefully I've been able to. Madalena, in obese patients with early moderate OA, is it clinically better to use open or closed chain exercises? That's excuse me. I think that's a good question. And honestly, I think the first question would be what's comfortable for them. There's plenty of exercises we can give them which are open chain or closed chain. I would always consider what's manageable for the patient, what's comfortable for them, what do they feel they can get on board with. Of course, you could start with open chain, which naturally would suggest to be a little bit easier because you're taking the weight off the knee when you're doing that exercise. But don't be limited to just open chain. People can benefit from closed chain. I would try and think about what's comfortable for them, especially if they're coming in. The main symptom that people will get from OA is pain. So we try and be mindful in the exercises that we give, that we're not over aggravating those symptoms.
Thank you, Khaled. So we'll come back to the questions and we'll sort of go back up them. I'm just quite interested to take things one step further there, where you've had physiotherapy for, let's say, 2 months, maybe 3 months. It's not really getting any better. You come back to me, let's say, hypothetically. I know that there's progressive move towards the musculoskeletal hubs where physios are referring straight on to the knee surgeons, but often I see people come back through me for more painkillers, for a bit more time. Sometimes we do try steroid injections, but rather than jumping on that bit, I'm just going to hand it over to Ray, the sort of things that you consider when people turn up to your clinic after trying these things, what your next steps were, as in when might you try steroid, or when would you do a replacement or a part replacement of a knee?
Sure. Thank you, Jack. Well, I think by the time they've come back to me, they've probably tried everything possible. So they've tried all the things that you've given Jack, and also Khaled's tried the physiotherapy. I think they've got to the point, they're pretty desperate by this time. They've tried for so long with conservative measures to try and improve the knee pain. It doesn't improve. I agree, a lot of them have a very high BMI, and that's very important that they try and reduce weight, because obviously that will improve their function and also their symptoms as well, and also improve the surgery as well. It'll make it more technically easier for me to do. So by the time they've got to me, they've probably got tricompartmental osteoarthritis. There's very little point in sending them back to Jack or Khaled to do more physiotherapy. If they're fit enough and they've got very few medical comorbidities, then you can then offer them a total knee replacement. If it's an elderly patient with tricompartmental osteoarthritis, then you offer them a total knee replacement. Even if they've got unicompartmental osteoarthritis, if they're 70 or 80 years old with only one compartment affected, you would still offer them a total knee replacement. There's little point in an 80-year-old having a unicompartmental knee replacement, and may need further surgery at a later stage to convert it into a total knee replacement. Unicompartmental knee replacements are more sort of for younger patients with disease that is confined to one compartment. So usually when they've got to me, they've probably tried everything. Now, the question you asked me was whether you should try an intra-articular steroid injection. Again, I don't feel there's any point in doing that when they've reached the point that they've got such severe osteoarthritis. need a knee replacement. But some patients do request a steroid injection. They don't want to undergo a knee replacement. They'd like to try a steroid injection. They last for a few months, if not, 3 or 4 months, maybe longer, and they may need to be repeated. So I offer that to them if they're absolutely adamant they don't want surgery. But generally speaking, if they're very keen to have surgery, I'll put them on the waiting list to have a knee replacement.
On the point of the steroid, which sort of overlaps one of the questions, how many would you give a year if they just kept coming back to you and saying, well, it worked for 3 months?
Yeah.
Would you give another after 3 months? Or
I would probably give 3 a year.
three?
Yeah. Because what people don't know is that the steroid is actually quite toxic to the chondrocyte. So each time you give a steroid injection, it actually kills the cartilage cells. And also we worry about steroid crises as well. You know, when you give steroid injections, you have to worry about various other side effects. So 3 is usually the maximum we give a year.
Yeah, that's fantastic. Thank you. And I suppose that we've covered about, replacing the knee, perhaps, slightly younger person for a unicompartmental type of replacement. The steroids, of course, we're putting that only into a native knee, never into to an artificial knee.
No.
Just one question that Tom had mentioned about thoughts of sort of evidence around PRP. Injections in the knee and that sort of thing. I think, Khalid, you've covered this sort of stuff before as well, haven't you? I have to say I've not really done any knowledge of this.
It's no problem. So I'm just actually looking at the NICE guidelines for this, and they certainly say that the HA, the hyaluronic injections, do not offer intra-articular hyaluronic injections for the management of osteoarthritis. And I think that with PRP as well, unfortunately, I think the evidence surrounding it is not overwhelmingly positive. I think there's like every piece of every intervention there will be some yes, support it, and some no, don't use it. But I think that PRPs are largely on the less effective state.
Okay, so I guess we'll leave that there unless Ray wants to add anything. If we're not going to be using them,
we don't use PRP for joint injections.
Okay.
No.
That's enough said then, I suppose. So, Khalid, do you want to whiz up the questions and then we'll move things on so that we can progress to the next condition?
Certainly. I'll try and answer these quickly and streamline. Angie, question, because I've heard so many people in OA class that say that when it rains, their symptoms are so much worse. Is there a physiological reason for this? I am going to be totally honest and tell you that I have consulted Dr. Google, who talks about barometric pressure. Oh well, I should have asked Jack because I'm guessing
dry,
right
hot weather, isn't it?
Go ahead, Jack. Go ahead.
Yeah. Well, I mean, I think that's, well, you've already sort of said it, really. I mean, most people say that if they go to Spain or Portugal, somewhere very, very hot, their arthritis tends to get a lot better. And there's something there about the pressure within the environment that seems to have some sort of positive effect. I suspect that the warmth has some effect as well. Yeah. We know warmth around arthritic joints tends to be quite a soothing thing. Ray, have you got some golden nuggets to add here at all?
Not really. What you said is true. Patients come to me and say, actually, my knee's far better in the summer and really bad in the winter. And, I don't think there's any specific reason for that. I think, as you said, it's probably the heat.
Yeah.
Which is obviously, alleviating some of the symptoms. But I don't think there's any specific explanation for it, to be honest.
Yeah, I think there was some tenuous link between that and some barometric pressures in the environment. Anyway, so
I'm just running up the list to see if there's any others. How often would ankle pathologies injury lead to knee OA? I suppose, Nikita, it's probably less common with Ray in the room, as he's highlighted. Hip and knees do certainly have a relationship. Ankle, I'm sure there will be something, a long history of ankle sprains, or perhaps, dare I say it, significant overpronation maybe overloads the medial side. Perhaps I could say that, but I'm sure that lots of people would probably push me on that one as well. Marisa, thoughts on knee braces in the early stages of OA? Now, I do know that is certainly something that are used, and this, rather than being sort of a supportive brace, you can buy medial offloading braces that, as the name says on the tin, it offloads the medial compartment of the knee, and it aims to preserve the joint space. Ray, I wonder if you've had any experience with that?
I use that quite a lot. I refer
Super.
them to the orthotics department for offloading braces, whether it's a medial or a lateral offloading brace. Usually I do that for patients who have got a very high BMI, who are ready for surgery, but they're not ready because they've got a high BMI. And you give them a brace, and it does help to a certain extent. And hopefully by that time they can lose the weight, ready to have the surgery. So I do use that quite a lot.
Awesome. A couple of other questions. If patient has severe OA on X-ray and physiotherapy is not making a difference, thinking injection or straightforward for surgery, I think Ray's mentioned that, that surgery.
I'd go straight for surgery. I would
absolutely
do.
Fine.
Unless they were adamant.
Sure. Many patients asking where to use turmeric tablets. Any advice on this? I think, as you said, Afsana, there, I don't think there's an overwhelming evidence base for it, because otherwise the whole country would be taking it.
Yeah, just a point on all of the herbs. Thing to remember when anybody says about, because people use turmeric for their prostate as well.
Sure.
And I get asked this all the time with a whole host of different herbal medicines. It's as simple as this. If they really were that effective, it's a lot cheaper than the medicines, the physio, and the surgery. We would just give those things. At best, these things have an adjunctive effect. I think glucosamine has shown small amounts of evidence of benefit for people with arthritis, but I still think that a lot of the evidence around that is not great. But that's all that I really would ever sort of talk about. The rest, I think, is relatively placebo, if I'm honest. I have a feeling predominantly.
No, fair enough. I don't think there isn't a huge amount. A quick question from Sharif. Can you just repeat the types of steroid injections? So hyaluronic acid, not suggested. PRP is plasma-rich protein, not suggested. And then we go from there. Yeah, I think that probably covers the main questions on the chat. Jack.
Okay, so thank you for those. If you've got questions,
everyone, thank you so much.
Yeah, so I guess if you've got other questions, you can always email us, and we will get back to you afterwards if we miss your question. But for the sake of time, moving on to meniscal injuries then. So obviously 2 cartilaginous croissants in the knee that sit on top of the tibia. I suspect that they're significantly stronger than croissants. I'm sure that Ray can tell me all about how strong they actually are under an arthroscope. So meniscal injuries. I'm interested, Khalid, what you can categorize them as, because there's some that are referred to like degenerative, and then there's others that are acute, aren't there? And can you talk a bit about that? Because it's quite confusing.
Super, yeah, would love to. It's having worked in knee orthopedic clinics, it's an incredibly challenging conversation, because you often get the situation whereby a patient has had an MRI scan and the radiologist report has been sent to them, or a healthcare practitioner has simply read the patient the MRI report. And as you said, Jack, it's incredibly important to make the distinct difference between a degenerative meniscal tear and a acute meniscal tear. So, and of course, we've got an orthopedic consultant in the room, so of course important to get his view of this as well. But when the challenge with looking at MRI scans for meniscal lesions or meniscal tears is that a degenerative tear, different to a acute tear, they look very similar on scans if you just take one slide. So MRI scans are a series of slides. If you go from medial to lateral or from superior to inferior, an MRI scan is a series of slides rather than one photo, and you look at each slide to try and work out your diagnosis. And if you look at one slide, you might look at the medial or lateral meniscus, and you'll see, if you're looking at a particular MRI scan where the meniscus appears black, you'll see a little white line through the middle of it. Now that is it's suggested that is fluid in the meniscus, and the idea being is that when you have fluid in the meniscus, is it a tear? Now this looks if you take certain images in an MRI scan, a horizontal tear will look exactly the same as an acute tear, whereby the and therefore the radiologist will report there is a horizontal degenerative tear, and people will say, oh, there's a tear, right, you've torn your meniscus. And then they turn up to the consultant and they say, right, I've got a torn meniscus, so you're going to operate? And then the consultant says, I'm not going to operate on your degenerative meniscal tear, I'm afraid. And they say, no, I've been missing work and I can't believe this is happening. And it's a real challenge. Horizontal or degenerative meniscal tears are normal. They can be asymptomatic. They happen because they're degenerative. We get older, and you will sometimes they will present atraumatic. Sometimes they may have been there for 3 years, but then an individual has a trauma on the 4th year, and they go to their surgeon or they go to Ray and they say, oh yeah, look, I've had a trauma, I've got an MRI scan, says I've got a tear, but potentially that it was a degenerative tear that's been there for a while, and it's just that the trauma seems to coincide with the timing. So that is different to an acute meniscal tear, where you might often where there certainly will be a history of trauma, and the MRI scans will be slightly different. A lot of the time you look for that white line not being through the center of the meniscus and not breaking the sides. So if you imagine a box, there's a white line that doesn't touch the sides. Whereas with an acute or a full meniscal tear, you will have the black box and the white line will touch the sides or will go through more than one side. That is often something that's used to distinguish between the two. But please let me come to the honorable gentleman, Ray, to see if he's got anything to add there.
Khalid, you've summed it up very well. There are 2 types of tears, as you said. The one is the acute tear in the young person, where you have a complete tear that involves the whole of the articular surface on the MRI scan. And these are more serious, whereas if you did an MRI scan on everyone over 60, just an incidental MRI scan, they'll all have a degenerative tear. In fact, I'm 58 now, so I'm waiting another couple of years for mine. So you'd have a degenerative tear, but you'd always find osteoarthritis associated with the degenerative tear in the elderly patient. They all have OA. So when you have a degenerative tear of the medial meniscus, it is associated with osteoarthritic changes in the joint. Going back to the younger patient with the acute meniscal tear, those need to be, obviously, those can cause symptoms. And they generally present with symptoms of pain along the joint line, but it's usually the posterior joint line. This is very important, because if you feel the joint line, it's usually right at the back of the joint line they feel pain. And the other symptom they have is that they have difficulty getting off to sleep at night. It's a niggling pain, whether it's on the medial side or the lateral side. They have a niggling pain which stops them from getting off to sleep. Those are the classical symptoms of an acute meniscal tear. Now, you may ask which meniscus is involved more. Now, the reason why the medial meniscus is involved more is because it's more fixed. So the meniscus is actually fixed, whereas the lateral meniscus is very floppy and it gets out of the way when you have a twisting injury. So medial meniscal tears are more common than lateral meniscal tears. And the reason for it is because of the fact that the medial meniscus is well and truly fixed compared to the lateral meniscus. So how do we treat these meniscal tears? Well, it very much depends on the symptoms, as I explained. You don't have to treat every single meniscal tear with surgery. So let's go back to the degenerative tears in the elderly patient. Because the underlying problem is osteoarthritis, that is the primary diagnosis, not the meniscal tear. So you can treat the osteoarthritis by giving somebody an intra-articular steroid injection, if that's the case. If they haven't got severe arthritis to warrant a total knee replacement, you can give an intra-articular steroid injection. Whereas acute meniscal tears in younger patients usually require arthroscopic surgery, if only if they are symptomatic.
Thank you so much for that. That's great. So I'm just going to pull us back then slightly, to reverse here, and we will then hopefully answer the questions as we're moving through. So patient comes through to you with knee pain. We've mentioned, I think, that the degenerative sort of meniscal tear is in the, I hesitant to say the older patient group, but the over 60s on the whole. Whereas if you've got somebody that's 30 years old that's coming, I suppose that they are much less likely to have a degenerative meniscal tear. Yeah. Do the patients that have the acute and degenerative present the same on the history, or not? Do they present differently? Is the acute, just one trauma, and the degenerative is a multitude? I'm just interested to know if that's something that you see on the history.
Sure. So with your you'll often find that with the acute meniscal tears that everything kind of adds up. So there will be a history. Often you're talking about history of trauma, and often not exclusively, but often that trauma involves an element of deep knee flexion or an element of knee flexion with twisting. So for example, I was squatting down and I fell over, or I was doing a squat in the gym and I lost my balance, or something like that. Those are just some examples. Or very classical rugby, changing direction with a bent knee and therefore doing that. And we'll talk about ACLs with that as well. So
just going to say, Khaled, there that the commonest that I've seen is a dad that's on a bouncy castle. He's got it for his children.
Absolutely.
I've seen that at least a dozen times.
Absolutely. And so that totally, Jack, totally. And the idea being is that when they go to see a physio or they go to see a consultant or even Jack, and the question is, have you had what happened? And they'll describe that trauma, and you might well establish that before the trauma it was okay. Since the trauma, it hasn't been okay. So a very simple concept there. So other things that point to, do they present the same? You will often find with the acute meniscal tears that joint line palpation is one of the key diagnostic factors, because you're palpating along the joint line and that's irritable. And it's also likely that your patient will have a focal point of pain. It's not kind of here. It's not, I'm not really sure where it is. It's often it's there. It's right there. And I can press it and that's where it is. Oh, can I press it as well? Oh, now you've poked it and now it's irritable. So they can definitely find their point. And I had a point in my head.
What about? Well, I suppose that what I'm getting at, I suppose, is we've talked about, acute. They've had some sort of trauma, flex, twisting, loaded, process. Younger age group, probably an acute tear. The older age group, more degenerative. Sure, locking, giving way. Are these common things in both? Or
good question. So you very rarely get your locking with your degenerative symptoms, and it's quite important to have a quick chat about what is locking. What does it actually look like? So when you have true meniscal locking, which is commonly the case with a form of tear called a bucket handle tear, your patient presents with a extension block. They are unable to achieve full extension and they feel like it just can't move. They just can't get it to fully extend their knee. They try and lift it, they try and wiggle it, they try and use their hands, and it just doesn't go because the tear is physically causing an obstruction that does that. That shouldn't be happening with your degenerative symptoms. But patients' understanding of locking themselves may lead the conversation in the wrong direction, because you might say, do you get any locking at your knee? Yes, I get locking. And then if we don't ask, what happens, they start describing what they believe is locking, whereby they stand up suddenly and they feel a catching at their knee, or they're sitting on a chair for a long period of time, and when they get up from the chair, it's difficult. That's their understanding of locking, but it's not necessarily our firm grasp of locking when we're looking for those true meniscal tears.
Okay. What about giving way when people say my knee buckles on me when I'm walking?
Sure. Yeah. Great question. In my head, you're again trying to what do you mean by giving way? Because giving way is more commonly a ligamentous sign, whereby there is an element of laxity because the joint is unable to maintain its stability because ligaments are not working. But again, those common situations I describe, I stood up from a chair and it suddenly hurt. That's what certain individuals will understand as giving way. So it's really important that if you say, does your knee give way? And they say yes. Could you tell me what happens there? And you'll commonly what we might commonly find is that meniscal lesions by themselves don't classically give way. Some do, but it's a kind of a rarer feature. It's more of a feature of ligamentous sign. Of course, someone could have a ligamentous injury with a meniscal injury, so that's something to bear in mind. but I would certainly hammer down on, what do you mean by locking? What do you mean by giving way? That's often a really crucial point.
Yeah. And can you tell from the history or the exam for that matter, which type of tear that they have, or is that too difficult, do you think?
I think often, and please, of course, I'm going to jump in with Ray on this as well. If so, a classic meniscal injury to me, if I was going to describe a meniscal injury in 30 seconds on examination, they've come in with a history of trauma. It's painful to palpate right there, and this is where my pain is. Right? Can I press on that point? Ow, that's where it's really painful. Can you? How's your movement? Oh, flexion's a bit difficult, but you know what? I can't extend my knee. We now have probably one of the most classical meniscal presentations. So yeah, those are the kind of
that's useful though, isn't it, to just have those key points.
Sorry, Jack, and then you were saying, can you then tell what type of tear it is? Not necessarily, but when you have that picture, rather than thinking, oh, that must be a bucket handle tear, or that must be a horizontal tear or a vertical tear, at that point I would be thinking, this looks like meniscal pathology. I'm going to refer the patient to see the surgical team, where they may order an MRI scan to investigate that further. So from hearing those signs, MRI.
And I'm going to come to Ray now about, once you've got this history that kind of points towards a meniscal injury, let's say either really, examination, how important is the exam in sort of diagnosing these?
Well, examination is very important, as you all know. So, as Khalid quite rightly said, all the symptoms that he described of an acute meniscal tear usually have an extension block, and that is true locking. Patients don't realize that they mean true locking. They think flexion. They can't flex the knee is true locking. It's actually they can't extend the knee. Usually with a bucket handle tear, you may get a clicking sensation when the patient moves from flexion to extension, from extension to flexion. So a clicking sensation may be indicative of a bucket handle tear. But yes, clinical examination, they have joint line pain. As Khalid said, it's usually localized, but usually it's posteriorly based. If you feel along the joint line, right to the back of the joint line, that's where they get the pain. And they will have an extension block as well. You mentioned, Khalid, quite rightly about giving way. That is instability. Instability is indicative of a ligament problem by definition, and doesn't really apply to meniscal pathology, although patients may say that. And you have to establish between true instability or pseudo instability as well, where there's a false instability, where if you have, for example, the patellofemoral joint is a bit irritable, you can have a sensation it might give way. That's pseudo instability, but true instability is related to a ligament problem. So so clinical examination is very important, but obviously it's the adjunct is you do an MRI scan and that confirms the diagnosis.
What about special tests? Because you get taught all these things like, the Apley's compression, the McMurray's test. You've got people that make up things like the disco dancing one on the feet, which seems crazy. A loaded twist on the while stood up to make that tear just a little bit worse. Do you use them in practice, or are they specific, or are they just a bit rubbish and just tell you that the knee's painful? Or can we actually use any of these and actually find out something meaningful?
I think you've highlighted it beautifully there, Jack. For all of the above reasons, they're becoming less and less fashionable. I genuinely don't remember the last time I used a test in order to diagnose a meniscal tear. And of course, I'm afraid to say I'm human. I don't get them all right. But when I have diagnosed a meniscal tear, I haven't said, oh, it's because I did McMurray's. It's often the history of trauma, as Ray said, extension block, pain on joint line palpation. Totally agree with Ray about the posterior horn, the back of the meniscus often being more at fault. And therefore, those are some of the classic signs. As you said, Thessaly's, McMurray's, Apley's, all, if they are painful, don't necessarily tell us, right, that's definitely the meniscus there. Could I'm so sorry, I'm going to jump in and tell a very hopefully a comical story. So with meniscal pathology, one of the key things, as we said, is that it's pain on joint line palpation that might cause the issue. And one of the interesting things is that the menisci don't have nerve endings, or they don't have very good nerve endings. So why is it painful when you press on the joint line? And the story is that there was an American orthopedic surgeon who wanted to try and find this out. So he said to one of his colleagues, what I'd like you to do is giving me a huge local anesthetic on my knee and do an arthroscopy on my knee. I'll be awake. And what I'd like you to do is press on certain things. And when it's painful, I'll tell you. And the idea being is that they pressed on some of the synovial tissue and the connective tissue around the meniscus, and that's what was painful. So it seems to indicate to us that when there's pressure from the meniscus on the synovial tissue around it, that seems to what generates our pain. I think it's a wonderful story of the orthopedic cohort, as our wonderful friend Ray is a proud member of.
So we've thank you for that, Colin. And we've talked about investigation, which I think we did at the start, and then again we're talking about we're going to get an MRI scan if we think that someone's got a meniscal injury. So I guess then coming towards management of these patients, if we start with physiotherapy management, if I've got somebody with like meniscal injury, let's say that the knee isn't like fixed and they can straighten their leg fully, it's really sore. Can we rehabilitate these people, or?
Yeah, no, absolutely. You've made a really good point that actually, if they have true locking and they don't have that extension block, it can almost be a fork in the road that might determine things for you. So if they don't have the extension block, then there's no reason why we can't try rehab. And the idea being is that there are meniscal tears that people can go back to their sport, and they can go back to their activities. I've certainly had patients in the past. I remember having a patient who had been listed for surgery, and I was working with the orthopedic consultant, and we both looked at it and we both said, yeah, unfortunately they've been trying physio, they just can't get anywhere with it, we're going to list them for surgery. And then a month later, I think he called and cancelled his surgery, and he said, actually I'm loads better. And it just shows that sometimes just a little bit of waiting and a little bit of rehab can definitely help things. What kind of things do you do? Very similar to a lot of general knee pathology. You try and do exercises which are manageable for the patient, not stirring up their symptoms too often, activity modification, painkillers, and you're just trying to get the knee moving to see if things going in the right direction. And if they do, fantastic. If they don't, then it might be that you refer back to orthopedics. But you made a great point, Jack. If your patient has a sustained extension block, that's a different factor. So if they do have that sustained extension block, then as I'm sure Ray will come on to in a second, the orthopedic team like to know about that, and they don't like it to go too far down the line before they consider surgery. Yeah. Ray, am I right in that? Would you like to
completely agree. If they've got an extension block, you should do something about it because it's unlikely to improve.
Yeah.
So, yeah.
So I guess one of the things that some people ask me, Ray, which I guess I'll come to you on this one. We've tried physio, and they say, well, I've got this meniscal tear. Will it heal? Will it heal on its own?
Right. Well, that's a good question, Jack. I mean, as we all know, most menisci are avascular, aneural, and alymphatic. That's what we're taught. But the peripheral part of the meniscus has a blood supply. So it very much depends on the actual site of the tear. So there are three types of tears. You can have a red on red tear, you can have a red on white tear, and a white on white. Now, the white on white tears will not heal because they've got no blood supply, but the other two can heal. So the reason why they may improve, Khalid, as you mentioned, is that they may actually have started to heal. Now, you can repair the meniscus if they've got a red on red tear or a red on white tear, but not a white on white tear. So if they need surgery, you can think about more conservative measures by repairing the meniscus. And meniscal repair is becoming increasingly more common in younger patients, the athlete who has got high activity levels. Meniscal repair is really important because if you take out the meniscus, if you do a meniscectomy, the chances of developing degenerative changes are extremely high. And this is very much so for the lateral meniscus. There are lots of papers out there in the orthopedic journals that if you take out the lateral meniscus, the chances of getting degenerative changes within 5 to 10 years is extremely high because they protect the joint from any shearing forces, any loading forces, and prevents osteoarthritis from occurring. So nowadays, people are trying to repair the meniscus through an arthroscopic route.
That is interesting. So I suppose that if you've got a meniscal tear that, let's say it's a white on white that's not going to repair by itself, what when with the sort of partial meniscectomies and that, what sort of the things that is it just persistent pain that and obviously if they're getting sort of other locking elements to it that decide you to do the operation and accept the higher risk of arthritis from removing part of the meniscus.
If you take the more meniscus you remove, the higher chance they're going to get more severe osteoarthritis and much rapid onset of osteoarthritis. So some surgeons actually try and repair a white on white if they can, but usually unsuccessful. And the way you tell it's unsuccessful is that the patient continues to have persistent pain. But certainly more successful surgery is red on red tears or red on white tears. But white on white doesn't tend to work very well. But if you've got a high level athlete, 20 years old, high demand patient, then you might try and repair the white on white, and there may be a chance of healing, but it's very rare.
That's really interesting. This is a little bit selfish, this, Ray, but with steroidal injections, you'd mentioned about a degenerative tear. Do you ever do it in an acute tear? Put a steroid in the knee, or would you think better not?
No, I wouldn't do that because it would. Really, you're not dealing with the primary problem, which is the osteoarthritis. With a degenerative tear, it can settle the symptoms down quite rapidly because they've got the primary problem is the osteoarthritic changes. And that can actually improve the symptoms, but not in an acute tear. That's
great to know. That's great to know. Okay, so that's pretty useful then, Carla. Would you like to go through the sort of questions and try and
why not?
And we'll pass them on and then we'll move on.
Let's have a look at these. So here we go. Angie, do you normally find chondromalacia with meniscal tears? Angie, I'm wondering if you're talking about kind of patellofemoral chondromalacia, and it's not always the case, but it can be if they have specific patellofemoral pain pathology, but it's not always a very closely linked situation. George, do different types of tears present differently? You've mentioned, George, there, e.g. bucket handle. Your bucket handles are the one where you have the highest chance of locking. But otherwise, it's often quite challenging to know exactly which kind of tear the patient has, or even the extent of the tear from pure examination. Apart from when you see a huge amount of locking, you say, right, this is definitely a meniscal issue. But otherwise, if you have some of those classic signs, you might refer on. Tasha, lovely to hear from you, Tasha. Currently at a clinical placement in a military hospital, fit young gentleman, positive for all special meniscal tests and asymptomatic. Is there potential for conservative? Hopefully we've answered that. Yes, there often is. Keep an eye on it. If there's the extension block, as Ray says, the orthopedic team actually want to know about it sooner rather than later. Gone through some of those. How to differentiate between medial plica, Pezantserine, and medial meniscal tear? They are all in a similar area. Great question. So I think that the key thing with the medial meniscal tear there is, and as Ray alluded to as well, joint line palpation, and you're very specific on your joint line palpation, particularly the posterior horn towards the back of the knee joint is where you'll find that, and they often have their very specific pain on palpation. It's there, not it's kind of here. It's there. That's where they say it. Whereas your Pezantserine is more inferior to the joint line, where those tendons insert, where the Pezantserine tendon is, and then your medial plica often actually presents around the patellofemoral joint a little bit more. So hopefully you can differentiate with that. Would you refer for someone for MRI with degenerative meniscal tear? Sancho, I suppose often the case is that you may not know that it's a true degenerative tear until they have an MRI scan. You might just suspect, oh, maybe this is OA. But Ray, I don't know if you've got any thoughts on that. Would you refer someone for an MRI with a degenerative meniscal tear? My answer was, it might be that the MRI is what tells you that they have the.
Yes, I agree with you. We normally see patients with already having had an MRI scan.
Yeah, cool.
Which shows the degenerative tear and asks us to intervene. Really, yeah. Cool. So we don't actually arrange it.
Cool. This is a really nice question coming up, and Ray, I will absolutely come to you afterwards for this one. How is weight bearing status decided on after a meniscectomy and also meniscal repairs. So with my experience, meniscectomies can often be fully weight bearing quite quickly. With your meniscal repairs, it depends on the extent of the tear, and I think it also depends a lot on consultant preference. I've seen some orthopedic surgeons who say go for it, fully weight bearing, and some have said hinge knee brace, 6 weeks, non-weight bearing, because they want to protect the repair if they feel as if the repair is vulnerable, and they don't want a huge amount of twisting on the knee, so they say non-weight bearing with a knee brace that keeps everything in a straight line. Ray, any thoughts on that?
No, absolutely. It depends on the surgeon preference. It used to be the case that they used to keep patients non-weight bearing in full extension, but I think more surgeons these days actually will give you graduated weight bearing, partial weight bearing to begin with, and graduated flexion in a knee brace up to about 6 weeks. You'll know whether the meniscal repair is successful because the patients will not have any pain. So after 6 weeks, 3 months, they don't have any pain at all. You can do a follow-up MRI scan, which will show that the meniscus is repaired. If they still have continued pain, persistent pain, which is causing them to interfere with their quality of life, then the chances are the meniscal repair is unsuccessful. So it's all to do with the symptoms more than anything else.
Wonderful. Last question, because I know we're going to move on. Alana asks, interesting question. Would an arthroscopy be the next step if the MRI was clear and the patient has tried physio but has pain and symptoms after an acute injury? And I suppose that the idea there, Alana, is that it might be a meniscal injury, it might not. I think that if the MRI is clear and the patient has tried physio, one of the real questions would be, well, do we know what the diagnosis is? Because patellofemoral pain, for example, you will have a normal MRI in a lot of cases. You might have some changes like patellar alta and things like that, but the MRI will largely be normal with patellofemoral pain. Patients may try physio, but it might be too irritable with patellofemoral pain, but it doesn't mean they're going to have a scope. I think if the diagnosis is questionable, then sometimes you might have an examination-based arthroscopy where they go in to absolutely make sure, but I think those are going to be few and far between if the MRI is totally clear. But Ray, any thoughts on that?
Yeah, that's a very good question, actually. We have got a small percentage of patients like that. We try and dissuade them from having an arthroscopic examination because the MRI is quite specific. And if the MRI has indicated there's no specific knee pathology, it's unlikely through an arthroscope to find any. But there are some patients who are very, very insistent. And even though we have arthroscope patients with normal MRI scans and finding normal findings, and some patients are actually cured after the arthroscopy because clearly they want to know what's going on inside their knee. But we try and dissuade patients from having an arthroscopy because we normally don't find anything, to be honest.
And if I may, I love that, Ray. Thank you so much. There is a very consistent side effect of having arthroscopy, and that is pain. And pain leads to quadriceps inhibition, and quadriceps inhibition leads to patellofemoral pain. And so as I totally agree with Ray, if there's no reason to have an arthroscopy, try and avoid it.
Brilliant. Thank you very much. Thanks for the questions there. Brilliant.
Lovely questions. Thank you.
Okay, so final one then. The ACL tear, so the anterior cruciate ligament tear. I'm actually going to start. I mean, Carla, this is pretty much like your sort of specialist within a specialist area, isn't it? I mean, you worked in A&E diagnosing these off the bat with people walking in. Yeah. So I'm going to come to you first and say,
please do.
Tell us about the cruciate ligaments for people that, you know, because I might have been sat in that chat when I was doing physio thinking, I don't even know where they are and what they do. So, you know, it's great to know what the tear is, but, you know, where are they? What do they do?
Thanks, Jack. No, it'd be a pleasure. So the cruciate ligaments, we call them cruciates because they present like a cross, cruciate cross, and they present as a cross through the middle of the knee. You've got the anterior cruciate ligament and you have the posterior cruciate ligament. I often say the three anteriors. The anterior cruciate ligament attaches to the anterior tibia and prevents anterior translation of the tibia. And then you have the three posteriors. The posterior cruciate ligament attaches to the posterior tibia and prevents posterior translation of the tibia. The ACL is much more commonly injured than the PCL because the knee is much more unstable or has less supporting structures in the anterior translation direction. So if you have a patient who has a valgus twist, is the common mechanism that pushes the tibia forward, and really, apart from the hamstrings, it's the ACL which is the main supporting structure. Whereas with the posterior side of the knee, you've got the PCL, and then you've got a lot of other supporting structures, including the posterior lateral corner. The posterior lateral corner is a subset of posterior structures that includes the popliteus tendon, the popliteofibular ligament, and the lateral collateral ligament that provide a lot of extra stability to the posterior lateral knee. So the ACL is commonly more injured than the PCL. Yeah, I'll start with that.
Fantastic. Yeah, that's great. So we'll move it on from there then. History. Ray, what's the classic history that you see of people come in with like an ACL tear? What sort of things trigger this? This is probably an ACL.
Well, there is a classical history. As Khaled explained the mechanism of the injury, it's usually high-level sports. In fact, usually, I think you'd agree with me, Khaled, that the majority of cases are non-contact sports.
I absolutely
so
agree,
about
Ray.
70 to 80% involve non-contact at all, whereas 20% involves contact with another person or whatever. So they usually present with an instant swelling of the knee, hemarthrosis that occurs immediately, and the patient, the person concerned will not be able to continue with the sport. They try and stand up and they collapse, and they have an instantaneous hemarthrosis, and that's where the diagnosis of an ACL until proved otherwise. So it's an hemarthrosis, and they can't continue with the game at all.
Right. Brilliant.
Wonderful.
So just to clarify, the hemarthrosis is it because the ligament's torn and it's bleeding into the joint? So you get that immediate swelling. You're not talking about me saying, I went home and then I woke up the next day and my knee was swollen. We're saying it swelled within
straight
away. Yeah.
But what you described there, Jack, is when they go home and it swells up after 48 hours, 24, 48, is a meniscal tear.
Right, there we get, exactly. So fluid over sort of it being blood.
So it's an immediate hemarthrosis, and it's got to be an ACL or a severe ligamentous disruption.
Yeah, excellent. Okay, that's super, super helpful. So we've kind of got that. So we talked about presumably a younger person there. Do we get degenerative tears of the ACL or not
usually?
Really?
No, very unlikely. Okay. I don't know if you've seen them at all.
No, I agree, Ray. You very rarely get degenerative tears. You do get so not always, but sometimes you do have people who are in the perhaps between 40 and 55 age group. I've seen a couple who have torn their ACL. As we get older, we are less engaged in high-level pivoting, twisting sports, which tends to injure the ACL. So that's one reason why it's less common. Also, we have OA and things get a little bit thicker, which can sometimes help with stability, believe it or not. So that's another reason why you don't always get it in the older generations.
So I'm going to bring you then, Khaled, to examination, and when people come into that environment that you've seen. What just really specific exam wise?
Sure. I'll be very
what
specific.
Are you looking for on exam? Just examination stuff that says this is an ACL, because I know that some people, they've got so much pain. It's hard to do some of the examination, as I understand. So tell us about that side of things.
It's an absolutely super question, Jack, and you're spot on that, as Ray has said, because they're often so swollen and so painful, it's difficult to examine. And therefore, as Ray absolutely spot on alluded to with his subjective signs, the subjective history is the key to diagnosing ACL tears. It is, as Ray very much said, valgus mechanism is the most common one, non-contact, pivoting sport, absolutely very quick swelling, hemarthrosis, unable to play on. I couldn't agree with Ray more on that. Pop, the sound of it, if you hear a pop, then you should consider that it is an ACL until ruled out. But it's important to say that not every ACL does present with a pop. But I have I'm very grateful that in the past I've been able to develop a relationship with my orthopedic consultant where I was working, whereby if I say, dear Mr. Surgeon, I had a patient, non-contact, twist, swelling, couldn't play on, he wouldn't mind if I hadn't done that much of a thorough objective, because he knows that we can use that information as one of the key things for diagnosis. However, objective examination, if I could go through it quickly, absolutely, as Ray said, is there if it's relatively soon after their trauma, is there still that swelling there? Sometimes patients feel better about a week or two later because the swelling might have settled down a bit, because they might have been able to start weight bearing, and actually they can start weight bearing. So that can sometimes be a red herring. But range of movement wise, it could be that their range of movement is limited because it's painful. It could be that they have an extension block because they have a meniscal tear as well as the ACL. And there's another thing that can block extension, which is something we call a cyclops lesion, where if you have the ACL from its lateral femoral condyle to the anterior tibia, when it tears, the distal half of it, the tibial part of it, kind of resects or retracts, I should say, and kind of gets stuck, and it kind of blocks movement. We call that a cyclops lesion, because when you look at the knee from a AP on an MRI, you can sometimes see this little black spot appearing, which looks like a cyclops eye. Yeah. But it's important for me to say that that lack of extension is not always a feature, but if you see that, you're definitely referring on. And then really it's going to come down as in a confirming manner to your Lachman's test or your anterior draw test, if you can perform them. Now, if you can perform them and you're looking for two main things with there, the first thing that you're looking for is an increase in laxity. And I think if you ask the question to most people, what are you looking for with an anterior draw test or a Lachman test, they'll say increase in laxity. Absolutely correct. But there's another really crucial thing that you're looking for, which is a lack of end feel. Because when you have a good ACL, intact ACL, when you do your anterior draw or your Lachman's, you should be able to feel a tug, which is the ligament intact saying, you can't move me any further because I'm here stopping you, pulling this tibia all the way forward. So when there's that lack of end feel, when it feels, technical term here, mushy, they often say it feels soft or a mushy end feel, that's because there isn't an intact ACL. So when you pull it forward, there's nothing to stop it. And therefore, you're looking for the laxity and or the lack of end feel. And I've diagnosed plenty of ACLs based on the lack of end feel. But Jack, you made an absolutely critical point earlier. You can't always do those tests because the patient will start punching you if you try and do them. So subjective history is the most important part of it.
Okay. So like in a partial tear, something like that, you may still get that tug feel, but it may be very, very painful perhaps to do,
absolutely.
as well.
It may not always be. It might be painful, but it may not always be painful. But I think, as you've made a really good point, that's where the subjective history is even more key. So if you, the relationship I developed with the surgeons I was working with was that if I do my Lachman's or anterior draw and I'm not sure on the strength of the subjective, he would be happy for me to have referred it, to the extent whereby he would have known that if I hear that history and I refer it through and he sees them 3 weeks later and he says, Khalid, there's no ACL tear here. What are you talking about? He'd be happy with me referring because of the subjective.
Okay. So excellent. And then if I come to you, Ray, in terms of investigations, when you think somebody's got an ACL, do you just go for the MRI scan? Is that what we should be doing, or?
You do. Can I just go back to Khalid's,
please?
What he said? I completely agree with you, Khalid. You have to do those two tests. The reason why you have to do the anterior draw and the Lachman's is that, just going back to the anatomy, the ACL consists of two sets of fibers. There's the posterolateral fibers and the anteromedial fibers. Now, the anteromedial fibers are taut in 90 degrees of flexion. Therefore, when you do the anterior draw, you're testing one of the fibers, the anteromedial fibers. The posterolateral fibers are actually taut in extension. Therefore, when you do a Lachman's, you're testing a different set of fibers. But clearly, if they're both positive, then the whole ACL is gone. Both the sets of fibers have gone. And the endpoint is so critical. It really is that feel of the endpoint when you explained that very, very well indeed about the mushy feeling. That's really important to elicit as well. But anyway, going back to your original question, yes, you'd get an MRI scan immediately as soon as you can if you suspected an ACL rupture, yes. But remember, Jack, the ACL, when it ruptures, 50% of cases, there are other injuries as well. So whether there's
why is that, Ray? Why do you get
because
other
of the
injuries as well?
because of the mechanism of injury. It's quite
Okay.
it's a deceleration injury, and it's a valgus injury, and it's a pivoting injury. It can injure other structures as well. So 50% of cases, they're associated with other injuries such as chondral damage, meniscal tears, MCL injuries, posterolateral corner injuries. So that the reason you get an MRI scan is for that as well. That's the most important reason why you want to rule out any associated injuries with the ACL. That's the reason why you get the MRI scan.
Excellent. Okay, so we've got our MRI scan. We know that the patient, let's say, has got a full or a partial, it doesn't matter, rupture of their ACL. Management options. So I'm actually going to just come to you, Ray, and just say, are there a subgroup of patients that you would just say, oh, I think we should go for conservative management on this over operating?
Yes, absolutely. If you've got a high-level athlete who has high level of activity, then you'd be more inclined to reconstruct their ACL. But in the majority of cases, they're not usually high-level athletes requiring high activity levels. So you would try conservative treatment to start off with, and you'd send them to somebody like Khalid for a good ACL rehabilitation program and see how they get on. Because the only indication in those patients to operate is instability. If they don't have any instability, then you don't need to operate on them.
Okay.
But obviously the high level athlete, you may well operate this straight away. But the majority of cases, they don't fit into that category. And some ACL rehabilitation is very sensible.
And just to be like over the top clear, when you say you're looking for instability, what sort of things are you referring to where you say, oh, we need to operate on that, as opposed to, oh, we can probably manage that conservatively?
Good question. True instability, what I elicited on earlier, where they're walking and then suddenly the knee collapses on them. They don't have any pain, they just collapse. That is true instability, and that's indicative of a ligament problem. So that's when you would say after a trial of conservative treatment, you'd most likely operate on them.
Yeah. So, Carly, tell us a bit about those patients you've seen, non-operated or non-operable, and you've at least tried conservative treatments. What do you do?
Yeah.
And what have you seen? Does it work a lot of the time, or? I'm just interested to know.
No, absolutely. I totally agree with what Ray said a second ago about the instability. It is absolutely the key feature. I think one of the other things to bear in mind is that you sometimes have patients who, it's a real discussion point. What is going to bring on their instability? Sport. So, patient Smith, you've just torn your ACL. You do have an ACL tear. So would you consider, are you planning to go back to sport? No, I'm not planning to go back to sport. I'm not planning to put my knee in those vulnerable positions that are going to bring on that instability. Okay, well, in that case, would you like to have an operation? No, actually, if I can do without it, I'll do without it. So that's sometimes you see. So yes, absolutely. Plenty of patients manage with conservative rehab based on the fact that, as Ray said, that they don't have that instability. It's critically important, and I'll touch upon something with that later. But if they are going through conservative management, then there's a couple of factors, really. Number one, get their range of movement back through various range of movement exercises. You're going to naturally try and improve their strength of the gluteal muscles, the quadriceps muscles, the calf muscles, and crucially, the hamstring muscles, because your hamstrings attach to your posterior tibia, and therefore they can help to pull the tibia back in the situation that the ACL no longer can. So they almost provide a secondary anterior restraint. So the hamstring muscles are crucially important. The other key thing to think about is that it's a ligament that's torn, and if the patient has instability, then you're going to try and work on proprioception, because it's going to be your proprioception and improving proprioception that tries to improve their stability. And I'm sorry that I can't stand up and show you, but you can try and progress people from. So, for example, if you think about what we commonly call a clock face exercise, where you're standing on one leg and you're bending the injured knee, and the other knee is kind of out in front of you, so you're reaching that other knee forward towards 12 o'clock, 1 o'clock, 2 o'clock, and your injured knee is the bent one. So you start in that kind of straight line position where your injured knee is only moving forwards, but as Ray and I have said, the valgus instability is the problem. So once the patient is comfortable with bending their knee and operating in a straight line, you then might think about trying to get them to be able to bend their knee with an element of valgus twist, because you need them to be able to control that valgus, so that if a valgus happens in the future, they don't give way, because they've practiced so many times to manage their proprioception within that.
And without sort of going through specifics for rehab just here, because I know it's an enormous part and
Sure.
takes hours to explain. If you were to see somebody that's been operated on, so they're post-operative, or those that have not been operated on, do you follow the same rehab protocols, or are they quite different?
Yeah, great question. And there will be some differences between the two. I think that I mean, proprioception is very important in both, but I think that the proprioception is probably even more important in the conservative. In the post-op, it might depend on what graft they've had. So if they've had the two most common grafts are a hamstring graft and a patella tendon graft. The quadriceps tendon graft is an emerging graft, but the first two are the most common. And so if you've had a hamstring graft, then you will do less hamstring work at the beginning, because the surgeon will want the original hamstring to repair itself without being too overloaded. And a similar kind of thing for the patella tendon. You do want to load the quads in order to engage that patella tendon, but you just might think about that a bit more. But otherwise, there are a lot of similarities. One of the key rehab protocols that is world renowned is the Melbourne ACL 2.0 rehabilitation guide, generated by Mick Hughes and another gentleman from Australia. Absolutely superb. And there are a lot of crossover principles and some slight differences that hopefully I've mentioned.
So people can search for that, can they?
Yeah, absolutely. Free. We've got it. We've got it on our ACL webinar, on our ACL injuries webinar. It's mentioned on there, and a lot of the exercises are mentioned on there. But yeah, you can download the ACL 2.0 Melbourne. Yeah.
Excellent. So just coming to Ray then briefly about sort of the surgical intervention side. Sort of operations that are offered to people in terms of repairing the ACL. What I mean, Carl has mentioned sort of the graft sites that are taken. Is that all that we do? Do we offer synthetic as well grafts, or pros and cons of things, or?
Synthetic grafts are not normally offered immediately, but if the ACL has failed on several occasions, then you may offer synthetic grafts. But as Khaled alluded to, the two main grafts that you use, the patella tendon graft and the hamstring graft. And where the hamstrings insert into the proximal tibia, it's called, as you all know, it's called the pes anserinus. Two of the tendons are taken and they're strengthened, and most surgeons now use the hamstring graft, and it tends to work very, very well. The most important thing is when you're constructing the ACL, you must try and reproduce the exact site of the ACL. So where it originates on the originates on the anterior tibia, and going on to the lateral femoral condyle. The graft needs to be very posterior. If you go too anterior, then it'll cause problems. So the siting of the actual graft is extremely important when you do the ACL reconstruction. But nowadays, the hamstring tends to be used more than anything else.
And in terms of sort of when people can sort of really load up that graft afterwards, how long are we talking after operations? I mean, before
most surgeons tend to load the graft fairly quickly. It used to be the case where you used to leave it 6 weeks before you loaded the graft, but most surgeons now get patients. It's a day case procedure now. Most patients go on the same day and they get on with things, and physiotherapy is started immediately I think you'd probably agree with that, Carly.
Oh, definitely, yeah. There's a lot of well, it's not emerging evidence. There's a lot of evidence to suggest that we should be going through weight bearing rehab quickly. And I think I totally agree with you, Ray, in the past that you may have seen a lot more non-weight bearing, whereas now we see a lot more fully weight bearing. The only caveat I would say sometimes is that when there is a meniscal tear as well, so if your patient has had an ACL with a meniscal repair, sometimes that differs, but otherwise I totally agree with Ray.
Okay, so they'll be weight bearing pretty much straight after the operation, will they? Would you say?
Yeah,
or will it take a little while?
Yeah, absolutely. Yeah. So it'll often be toe touch weight bearing. Excuse me. Please ignore that. It will be weight bearing as tolerated, which at the early stages might be that it's just partial weight bearing, but then as soon as they can fully weight bear, then they can go for it.
What I want to know, Carly, just really broad strokes here. What are the rehab things that you're doing, like from week 1 to like 3 months? What are you doing to get them back?
Sure. No, absolutely. I'll try and be quick with this. As you said, it could take ages. So early stages, really important to try and get range of movement. You do not want to lose extension and not have that extension come back. That is a problem. If you have a patient who is approaching 6 weeks post ACL and they haven't gained full extension, the consultants want to know about it. Is there a Cyclops lesion in there? Or is there kind of tissue that's blocking things? And so they want to know about it because they might need to go back in to remove that. So you want to get extension very quickly. You definitely want to get the quadriceps muscles very quickly working. So in the early stages, you'd be doing things like static quad, you'd be doing straight leg raise. There's evidence out there and consultants vary as to whether they are happy with your patient doing a straight leg raise if they have a lag. What I mean by that is that if you do a straight leg raise and you can maintain your knee fully extended, there's no lag. If when you try and do a straight leg raise, the knee flexes because your quads can't maintain the extension, that's a lag. And some surgeons will say, I don't want you doing a straight leg raise until there's absolutely no lag. And some will say, no, that's okay.
Okay.
So after a couple of weeks, you'll be generally looking at getting into standing exercises, really important because, as we said, the weight bearing and the loading feeds into the proprioception, critically important. So you'll be trying to do things like sit to stands, standing on one leg, heel raises, single leg heel raises, bridging, single leg bridging. And you are normally aiming that around about the 6 week point, your patient has definitely removed their crutches. They're definitely walking independently. They're definitely with full extension for the reasons we've said. And they've got relatively good control of their knee. They shouldn't be feeling any instability because you've done all that muscular strengthening. Around about the 6 week mark, they might be considering going into some kind of intermediate leg class if people in the NHS are relatively familiar with that kind of thing, where they're going to be doing kind of midterm strengthening exercises. Return to running at points between 10 and 12 weeks. There was a recent study that suggested that in order to return to running post ACL, they found some of the most important signs were 12 weeks, 95% knee flexion compared to the other side, less than 2 out of 10 pain, definitely good extension and really good quadricep strength. And then going on towards the again, very dependent on what protocol you read based on the consultant criteria and what their surgical preferences are, but you might be looking at around about 16 weeks as the time, around about the time that you can start introducing multi-directional activity. So can you do squats or can you do lunges, which have a little bit of change in direction? Can you start jogging between cones side to side? But a really, really important point for me to mention, I'll hopefully finish off this section, is that time after surgery is definitely an important factor, but crucially important, which we're seeing more and more within ACL rehab in particular, is not just time, but physical criteria. So for example, even if it's been 16 weeks, but your patient can't do a single leg bridge, it's not the right time. They need to be able to pass physical criteria tests, such as, can I do 25 single leg bridges on the operated side? Can I do 25 single leg heel raises? Can I do 1.5 times my body weight on a single leg press? And if you want some ideas of those different protocol measures or the guidance you should follow, once again, ACL Melbourne 2.0 guide, brilliant resource, goes through all of those and a lot of the key physical tests that they should meet in order to be able to progress to your multi-directional stuff and things like that.
Do you mind me just asking briefly then? You mentioned extension a lot. What about flexing the knee?
Yes. So that should come back relatively quickly. You should be able to get close to 120 degrees of knee flexion after 2 weeks, or if not before. But certainly by the 3-4 week mark, you definitely want them getting 90 to 95% knee flexion. It's something that you definitely want to keep an eye on.
What do you give them in terms of like going up and down stairs and flexing the knee and going beyond 90 degrees, things like that, early, or does it not really matter?
No, they should be able to go up and down the stairs relatively quickly. The difference with the going down the stairs sometimes is that when you're going downstairs, it kind of knee flexion, potential point of the valgus if they're unstable. So they're allowed to do it, but they just have to keep an eye on it and make sure that they're comfortable doing it. Imagine that if you're properly going down the stairs, then it's a little bit like a single leg squat if you're really trying it. So you find that in the early stages they kind of not hop down the stairs, that they literally jump, but you find they spend very little time weight bearing on that leg when they go down the stairs. But they're definitely allowed to. Yeah.
Okay, fine. They're allowed to sit, bend the knee to 90 degrees, stand up again, things like that. So that,
totally.
they can.
There shouldn't be any range of movement restrictions with ACLs.
Great.
99% of the time.
Is there anything else you want to add, Ray, before we go through the questions that are?
No, I think Carly's covered the post-operative regime very well, so that's good. Yeah. So yes, you need to get them as quickly as possible, getting back to normal again. And I think it's fair to say that contact sports, we tend to wait about 9 months to 12 months or earlier than that.
No, I think you're spot on, Ray. I think that lots of surgeons look at that kind of 9 month range, 9 to 12 months. But once again, we're finding more and more studies that look at when ACL repairs fail. It's when patients are going back to sport too early, either because they went before 9 months, or they went back at 9 months, but they weren't able to meet those physical criterias. They didn't have enough strength, they didn't have enough power, and that's what failed them. So as you said, the time, and also can they meet those measures? Once again, Melbourne ACL 2.0.
Brilliant. So perhaps, Carly, if you want to go through the questions and we wrap up
certainly
those.
Absolutely. Success rate, please, Ray, if any of these sound like a question you'd like to jump into, please as well. Success rate of ACL surgical repairs, normally very, very good. Rehab is an extremely important part of the surgical process, a lot of consultants will say. Ben, is it an option for an elite sports person to return to high-level competition without surgical intervention following ACL? Really nice question. I totally echo what Ray was saying earlier here, that when you have those elite sports athletes, they are going to have surgery the vast majority of the time. There might have been the odd exception, but one of the huge reasons for that and why they need a stable ACL is that when you're doing those elite sports with lots of pivoting and lots of jumping and lots of landing, and you don't have a stable ACL, that's when you get secondary meniscal tears. And one of the biggest factors as to the research of, oh no, physiotherapy can manage the vast majority of ACL tears. Sure, they can. But when you have a patient who has an unstable knee, as Ray absolutely correctly said, and they have instability, and then they go back to high-level sport, they then are more at risk at getting a secondary meniscal tear, which sometimes are irreparable. Then you have huge problems. You have massive problems, because you now have an unstable knee, you have an irreparable meniscal lesion, and as Ray said, you don't want to repair those, you don't want to remove those because of the OA risk. And I've got a quick paper that I mention all the time. Very quickly, 2019 study demonstrated that 16% of non-operated ACL injuries often go on to experience secondary meniscal tears. That's quite a high rate, and I'm sure it expands further on that. So Any outcome measures you should use to identify when the patient is ready to return to sport? Diana, I hope I've been able to answer that. Melbourne ACL 2.0. Google that. It'll give you all you need. Are there ACL precautions pre-operation? Oh, good question. A lot of the time there aren't, but it depends on if someone's massively unstable, then you just be saying to them, don't go to sport, don't put yourself in high pressurized situations. Is patients able to go back to skiing after ACL reconstruction? When is the earliest time to do so? Carolina, great question. Often they talk about a little bit longer. They talk about 12 months for this. I'm not a skier, so some of the I've heard in the past that you need to use lower binding points, or there needs to be a difference in the binding points to make it easier for the skis to release so that the ski doesn't get stuck in the ground, but you can. Great question, Sanjay. Is the surgical repair suggestive for medial meniscus and ACL at the same time? Yes, if you can repair both at the same time, then very commonly it is done. And I believe that is all the questions.